my talks were it's about mimics of pancreatic cancer. As you know, wherever we can find people who looks the same, but some are very bad, some are good, some ugly. And of course, in pancreatic lesions, ductal adenocarcinoma is the bad one. It's called the silent killer. All we know why. It's a late clinical manifestation, lack of capsular infiltrative pattern of growth, and has a rich lymphatic network, which leads to metastasis. What is most important from a histological point of view is the presence of fibrous stroma gives a serous appearance. That means that there's a low vascular network, and the consequence is an hypo appearance. It's a hypoechoic, hypodense, hypointense after contrast media. So typical a sample of a lesion, which is a hypovascular with hypointense appearance, also in the delayed phase with the stenosis of the Wirsung duct and the dilatation upstream with signs of chronic pancreatitis, which does not reverse after secreting. So if this is the bad, which are the other ones can simulate a bad one? Of course, we have chronic lesions simulating pancreatic tumors. The most frequent are paraduodenal pancreatitis, focal chronic pancreatitis, and autoimmune pancreatitis. So this is the ugly, because of course these are chronic pancreatitis and can lead to, if untreated, to a bad quality of life of these patients. Paraduodenal pancreatitis pathogenesis is still unclear. What we suspect is a pancreatic heterotopia trapped within the duodenal wall, and so the lack of an effective juice output system causes inflammation and fibrosis. Inflammation and fibrosis, it's also caused mostly by alcohol and smoke, and there is a quite typical clinical profile of these patients. These are male, in most of the cases are male and middle-aged, drinkers and smokers. So whenever you suspect of paraduodenal pancreatitis, this is the clinical profile. Paraduodenal pancreatitis can show up with a large cyst or with a small cyst and giving a solid appearance. And this is the problem of solid appearance, which can simulate a pancreatic carcinoma in the groove region. So alcohol intake causes the formation of protein plaques, which has obstructed the flow of pancreatic secretion. Tobacco enhances ethanol-induced pancreatic injury. Which are the imaging findings of paraduodenal pancreatitis? The lesion typical is located on the right of the gastroduodenal artery, like pancreatic carcinoma is a hypodense, hypointense. We can find some cysts in the lesions. The lesion is hypovascular, but in the late phase, in the venous phase, can show enhancement in the typically in the late phase. There is enhancement. So remember, gastroduodenal artery is a very important landmark. Usually, paraduodenal pancreatitis is located rightward of the gastroduodenal artery. In the beginning of these lesions, there is a sharp margins between the lesion and the pancreas, which is unaffected. By the times when we have a chronic obstructive pancreatitis, all the rest of the pancreas, these margins are less clear. So this is a male, 47 years old. He had the previous alcoholic pancreatitis, abdominal pain, and we see there is a lesion here located to the right of the. I shared it. I shared. Do you see it? Oh, sorry. I put inside. Okay, let me. Oh, okay. Yeah. Okay. I'll be. What a pity. Okay, I try to slide to. Okay, today it's a bad day. Okay, so do you see my presentation now? Okay, sorry. So, good, bad, and ugly. This is the bad, delta adenocarcinoma, hypovascular, so hypoperience, hypoechoic, hypodense, hypointense, a typical experience of a pancreatic carcinoma. So I already explained what happens here. And these are the differential diagnosis mimics of pancreatic carcinoma. Mostly these are chronic lesions simulating a pancreatic carcinoma, the most frequent paraduodenal pancreatitis, focal chronic pancreatitis, and autoimmune pancreatitis. We really talk about paraduodenal pancreatitis. It's an ectopia of a pancreatic tissue within the duodenal wall. There is a lack of pancreatic juice output that leads to inflammation, especially related to alcohol and smoke. Typical clinical profile, these are young male, middle-aged drinkers and smokers. Imaging findings, typically on the right of the gastrointestinal artery, and the lesion is hypointense with a poor enhancement in early phase, but a late phase enhancement. So once again, this is the gastroduodenal artery, this is the normal pancreas, this is the paraduodenal pancreatitis, and you can see this located rightward with the sharp margins at the beginning of the lesion, but by the time when the rest of the pancreas is affected also from chronic pancreatitis, the margins are not so clear. Male, 47 years old, lesions located to the right of the gastroduodenal artery. There are a small cyst inside these lesions. The lesion is hypovascular, but in the venous phase, in the late phase, there is a late enhancement, very typical of a paraduodenal pancreatitis. Another case, there is a small cyst inside, hypointense, hypovascular with delayed enhancement. The choledocus is not infiltrated, but usually is displaced leftward with some encasement of the visible duct with the signs of chronic pancreatitis upward. Another case, and we go fast. What is nice to see here is in diffusion, you don't see much high signal intensity on high B value, and ADC map does not show a significant restriction. This is because the hyperplasia of Brunner glands, there are in this lesion we have a hancinal elements and the cystically dilated ducts. That's why we don't see usually restricted diffusion here. On the contrary, this is a pancreatic ductal adenocarcinoma in the groove. You can see here on high B value, you see high signal intensity, and this is with the restricted diffusion the same map. So this is the differentiation with the pancreatic ductal adenocarcinoma in the groove. Remember, usually pancreatic carcinoma has a restricted diffusion. Usually paraduodenal pancreatitis does not have a restricted diffusion. So which are the most typical findings of paraduodenal pancreatitis? There is an increase of signal intensity of the late phase after contrast media, either isointense or hyperintense on DY. There is absence of double duct signs. There are some cysts within the lesions, and the lesions usually are bigger than a pancreatic carcinoma, and there is a focal thickening of the duodenum. Whenever you suspect a paraduodenal pancreatitis, send to the patient to endoscopic ultrasound to biopsy the lesion, because the sensitivity of a fine needle agobiopsy is very high, up to 98 for sensitivity, up to 100% of specificity. What about the ugly? Another ugly is a focal chronic pancreatitis. And how we make differential diagnosis with the pancreatic ductal carcinoma? We have to analyze the relationship of the mass with the ducts and with the calcification in chronic pancreatitis. These are morphological information. This is a focal chronic pancreatitis, and you can see here the inside the lesion we still can see the ducts, we can still see calcification. This is a ductal adenocarcinoma. You can see here, the ducts are displaced at the periphery of the mass. So these are important information to see what is going. You can see in this ductal adenocarcinoma, the ducts are displaced at the periphery of the mass. Or in this case, this was an incidental finding during an intervention for pancreatic dural anastomosis in chronic pancreatitis. There was a small tumor inside, and if we go back and see the CT, the calcification are displaced at the periphery of the lesion. So how can we make differentiation? So remember, usually in focal chronic pancreatitis, we have a delayed enhancement. Usually pancreatic adenocarcinoma is a hypointense. Inside the ducts after secretin, we can see back the duct. So we have a duct penetrating signs. We don't see in the pancreatic duct adenocarcinoma. On the contrary, DY is not helpful. And these are dynamic or function information. So there is a focal stenosis, there is a mass in the head of the pancreas, which is hypovascular, but in the late phase, there is a normal enhancement, and this was a chronic sclerosing pancreatitis. On the contrary, this is a lesion, is a hypovascular, hypointense in the late phase, stenosis of the main pancreatic duct, which does not reverse after secretin, typical signs of a pancreatic duct adenocarcinoma. Remember, after secretin, usually inflammatory mass, we are able to see again the ducts inside the mass. If we have a pancreatic carcinoma, we don't see. This is the so-called duct penetrating signs, and sensitivity and specificity are quite high to make to distinguish benign stenosis from malignant stenosis. Second, the MRCP is useful also if we follow up this patient with the chronic pancreatitis and we observe there is a stenosis which does not reverse after secretin. This was a pancreatic cancer in onset in a patient with a chronic pancreatitis. Is the Y useful? More or less, but usually ADC map is lower for pancreatic carcinoma than for mass-forming pancreatitis. Some papers report that with the IVIM technique, especially with the DSTAR and fraction FF, we can differentiate pancreatic carcinoma from chronic pancreatitis, where the signal is higher for chronic pancreatitis than for pancreatic carcinoma. This is the good. Why is good? Because this lesion has a good response to steroid therapy. So we can treat effectively this patient. Remember, we have two times. The type 1 is the most frequent, is IgG4 related. Type 2 is not related to IgG4, is related to IBD. We can have a focal, diffuse, multifocal pattern. However, symptoms can be similar to pancreatic malignancy. The diffuse form is the typical sausage appearance. Whenever we show it, we can make an easy diagnosis. The focal form is very similar to pancreatic cancer. So, which are the criteria according to international consensus to make a diagnosis of autoimmune pancreatitis? So we have 5 cardinal features. So, imaging features related to the parenchyma or the duct, the serology, especially increase of IgG4, other organ involvement, of course, histopathology whenever possible, not easy, and finally, response to therapy. When we have at least 2 of these criteria, we can make a correct diagnosis of autoimmune pancreatitis. The imaging, so we can have diffuse or focal. A peripancreatic rim in diffuse form is very specific, although not easily to see. Another important landmark is a long narrowing or in a short in focal form without significant dilatation upstream. Once again, these lesions have a poor enhancement in the early phase, but they show typically late homogeneous enhancement. The rim-like enhancement in the late phase and in the acute phase, the diffusion is very restricted. Sausage form, very typical. Peripancreatic rim, very typical. In this case, no problem to make a correct diagnosis. Stenosis without a dilatation upstream. This is autoimmune pancreatitis. This is a pancreatic cancer. You can see the difference between the dilatation upstream. So remember, when you see a significant dilatation, think about the cancer. Whenever you don't see a dilatation, think about autoimmune pancreatitis. What about dynamic information? I told you, this in the early phase, there is a poor enhancement, but they show a late and homogeneous enhancement, and sometimes they can show a rim-like enhancement. High value of IgG4, this patient had a previous Castleman disease, poor enhancement in the early phase, but homogeneous and late enhancement, typically for focal autoimmune pancreatitis. And I show you once again this one. Poor enhancement in the early phase, but homogeneous enhancement. And in this case, we can show also a rim-like in the very late phase. And we can see here, there's a long narrowing without upstream dilatation. What about function information? DY. DY shows usually especially in the acute presentation, a very restricted diffusion. And according to some paper, the restricted diffusion is higher for autoimmune pancreatitis, middle for duct catalytic carcinoma, and lower for mass-forming chronic pancreatitis. So whenever you see a very restricted diffusion, think about autoimmune pancreatitis. And finally, the response of therapy is very important. Of course, whenever if you don't have a high value of oncological markers, and you can suspect focal autoimmune pancreatitis, some societies suggest to have a 2 weeks trial to therapy, because the results are very effective. This is after 3 months, but we had another one in the middle. The lesion is markedly reducing the lesion, and also the diffusion is different. Here we have 0.9. Here we have after therapy 1.3. So DY is also a biomarker of response to therapy. The other, in type 1, we can have other organ involvement, typical bile ducts, retroperitoneal fibrosis, or salivary glands, or renal involvement. That's the most frequent. So in this case, we can easily characterize the lesion as autoimmune pancreatitis. However, it does not happen usually in the same time. In the relapse, we can observe a typical sausage appearance, a typically restricted diffusion. This is a diffuse autoimmune pancreatitis. Long stenosis without dilatation upstream, no double duct, typically. And very high value of IgG4. The patient that went well after therapy, but after a few months, not 1 year, but a few months, we saw a relapse of the therapy. We see a peripancreatic halo, but there was also jaundice, because we had a lesion in the hilum, and this was related to a relapse of chronic IgG4 systemic disease. In this case, it is not pancreas, but now there is other organ involvement. Usually relapse, other organ involvement is related to the high value of IgG4. So in conclusion, pancreatic adenocarcinoma is the most frequent lesion of the pancreas. Whenever you suspect needle deletion, the differential diagnosis with the other lesions can be difficult. However, morphological, dynamic, and function information can be helpful. And I thank you very much for your attention.